suicidal inhibitors. So with this type of interaction, you are not dealing essentially with a receptor. You're dealing directly, you're talking to the enzyme that does this work. Okay, so that's very important to appreciate and to understand and to place it on your hard drive. Certain drugs can combine with other chemicals, like antacids, for instance, antiseptic effects of alcohol, phenols, chelation of heavy metals. Chelation therapy, I have a colleague, actually, I have a friend, is in this business, chelation therapy, and he has a clinic actually in Florida, and he does very well, actually. All what he does is actually injects the patient with very low concentration of EDTA, ethylene diamine tetraacetic acid. Okay, and this compound, if you look at the molecular structure of the compound, it tends to trap the positively charged ions, the positively charged metals. So Wilson diseases, the problems deal with heavy metals, so you tend to trap those, and those can be excreted safely without any problem. So you release the tension of these heavy metals. And he's doing his business very well, actually. All what he does is inject the patients and sit, watch the TV for 2-3 hours. And it's mainly based on organic concepts. Okay, chelation therapy. Okay, changing cell membrane permeability. That's also another factor. Okay, so when we address actually as we stated in pharmacokinetics, one of the major parameters that you are dealing with is the molecular structure of the compound, right? You want to have a drug that works for you, right? Can pass this through this decent bilayer membrane. So those are the common mechanisms where you actually not required to have a receptor. Antimetabolites, exactly, that's what we said in terms of antimetabolites, can be actually substrate analogs of certain enzymes, okay? Interbiochemical reactions in place of the normal substrate. Look at the statin compounds, for instance. They all are competitors for para-hydroxymethyl coenzyme A, which is a key enzyme for cholesterol biosynthesis. So it results in biologically inactive product or inhibits those. So you have some examples here, anti-neoplastics and anti-infective agents. So all of this you're going to see, and we're going to share a good story that you will enjoy. You will enjoy it. Why? Because we understand it at this level. You will be going to enjoy it. Why? Because it's been addressed actually by an educator who believes highly in integration of basic sciences, who believe highly in looking at the big picture, understand it, digest it, not memorize it. Okay, with that said, let's move on and address agonists versus antagonists. And we like you to be familiar with this, and that's why I prepared you actually for the tough stuff, right? PNS, CNS, right? Okay, cardiovascular drugs. Why all students, oh, this is very tough. This is very tough. This is the fact that it's very tough because they don't understand what is going on. The fact that numerous students, oh, biochemistry, this is the toughest subject that we had in all our life. Oh, we're glad it's over. And why is that? Because you really don't understand it at the molecular level. Okay. Is it hard to understand? No, it's not hard, but you have to be interested in it. You have to join the club, okay, the winning club. You see, so that's the aspect that we like to, we like you to appreciate. You like to be able to fit the pieces together. You like to join the winner club who are looking actually to address the big picture. You see that? So like to see this chess game approach complete and fine. Like to see this pyramid built on a solid foundation. That's what I call education, not the picky stuff, and you're trying to memorize some from here, to memorize some from there, trying to squeeze by on national board exam, and you may be able to squeeze by, but you're still not competent enough really to the level where you put all the pieces together. You are not in a position to make a decision in a matter of seconds, because this comes actually with experience, comes with full understanding of what you're going or what you address. So I greatly urge you actually to do that as my responsibility as effective educator. An agonist is a drug that said when you say this drug is an agonist, and that's what we're going to address actually, cholinergic agonists, cholinergic antagonists, adrenergic agonists, adrenergic antagonists. So you have to understand what we're talking about. A drug is said to be an agonist when it binds to a receptor and causes a response or effect. So essentially, you initiating, you actually addition aspects for the in vivo biologically important neurotransmitters that exist, right? Or a biologically important compound that, so you're potentiating its effect. That's an agonist. That's what an agonist does. Right? An antagonist, in a reverse manner, a drug is said to be an antagonist when it binds to a receptor and prevents or inhibits. I like to use the term inhibits more. Okay. Inhibits a natural compound or a drug to have an effect on the receptor. So that's what you are dealing with at the terminology level. And then we're going to look at it at figures level. What is it going to do? Can we understand this material? Can we translate this figure? Do we have an appreciation about this? Of course, if you don't have an appreciation about what's going on, when you look at a figure, you're still not convincing anyone that you really understand what is going on. And that's what we like to emphasize. So that's an agonist versus an antagonist. When we look at pharmacological antagonists, and that's our objective here, so we're looking at competitive, and as the name implies here, they compete for the binding site. And we stated that, so it can be reversible or irreversible, okay? So you see the same pattern here with receptor agonist, receptor antagonist, and you see the same pattern with respect to non-receptor mechanisms in terms of drug action on a specific enzyme. This drug action on a specific enzyme can be reversible or irreversible in a similar manner. You see, partulin loves to bind with the flavine adenine dinucleotide moiety of monoamine oxidase. I lived with it. I lived with this drug, and I lived with this enzyme for years, okay, in order to analyze in detail the mode of action of those drugs and what do they do actually at the molecular level. So this nature is an irreversible process with respect to a non-receptor functions. Very much the same with respect to receptor functions. Non-competitive bind elsewhere in the receptor. Okay, so you're dealing with channel blockers or elsewhere. You have to appreciate the nature of the receptors. And I emphasize on that when I actually teach biochemistry. Those receptors are protein in nature. There are actually complex proteins. So you have to appreciate that. Complex proteins made up of several polypeptide chains, and they're subject to conformational change that take place when an agonist or an antagonist bind to it. Okay. So that's an appreciation about the nature of the receptor will help you actually to visualize what is going on. Okay. When we talk about functional antagonists, so we're talking about physiological antagonists or chemical antagonists. So the terms are interchangeable here. I mean, I cannot really differentiate between physiological, pharmacological, or chemical antagonists. They mean the same thing, but you have to appreciate the fact when we talk about physiological antagonists, so we're talking about a function of naturally existing compound or a hormone. And so that's the case what we are dealing with. A drug that binds to a non-related receptor producing an effect opposite to that produced by the drug of interest. So you're dealing with glucocorticoid hormones. We understand the physiological significance of glucocorticoid hormones, essentially to increase blood sugar by increasing gluconeogenesis process, right? Okay, so we understand this information nice. Okay, we said permissive effect, and I deal with that in a great deal when I teach endocrinology. That I actually in a process of publishing a text on it now. I love it. I love it. So insulin act in a reciprocal manner. Okay, so you have the opposing effect here. So insulin function as a physiological antagonist for glucocorticoids. So this is the understanding that you really need to achieve in terms of chemical antagonist here. So you're dealing here with a sequester. You're dealing here with a chelator, okay, a trapping agent. I like to refer to this as a trapping agent. I love to look at those chelators and look at the charges that they have. You see, that's my interest. Okay. A chelator is sequester of similar agents that interact directly with the drug being antagonized and is able to remove it or prevent it from binding. What is the nature of binding here is you try to take advantage of the charges that exist. So a chelator tends to trap this drug, and therefore it's going to interact directly with the drug that is being antagonized and remove it. So it relieves the so that's a chemical antagonist. It doesn't depend on the interaction with the agonist receptor, although such interaction may occur. What are the examples for that? Your old friend, heparin. It's an anticoagulant, acidic. If there is too much of it, of course, it's going to show side effects, bleeding, hemorrhage. Protamine sulfate is a base, forms stable inactive complex with heparin. So it removes it, suck it up, and inactivate it. See, so that's a chemical antagonist. All work for you here. Let's address additional terminology here. Synergism. What is synergism? As the name implies here, it's actually give you more than what you expect. So the combined effect of two drugs is higher than the sum of their individual effects. Additivity, it's a combined effect, is the same or the sum of the individual effects. And that's important to appreciate when you prescribe actually a medication to a drug. What you're trying to achieve here when you try to prescribe two different antihypertensive drugs, right, to a patient who suffers severely from a high blood pressure, but with different mechanism of action. So what are you trying to achieve here? You're trying to achieve a stable condition. That's what you're hoping to do actually with this site. Okay, so we did that. Let's move on. And this partial agonist. Partial agonist is a drug is said to be a partial agonist when it binds to a receptor and causes partial response. Okay, so it doesn't have to be a full agonist. It doesn't have to be a full antagonist. It can be a partial agonist or a partial antagonist. Okay, how can we see that? How can we see that graphically? That's what we like to address. With that said, let's move on and address some terms here that refers actually to drug efficacy, okay, and drug potency. Those are the two terms that always students actually do not get it right and confuse out of it. And the reason for the confusion is their lack of understanding of what's going on. I can tell you very, very frankly on that. I have students, for instance, when I used to address enzyme mechanisms and enzyme inhibition and stuff like that, I related to drug actions. Oh yeah, we understand everything, and then I bring the exam and I see the scores. Almost about 25 to 30 students really pass, and those are professional students. Those are people who actually they think that they got it made because they don't understand what is going on. All what they do is try to memorize some stuff that has no relevancy really for answering critical thinking questions. And then when I challenge them, when I go over the exam. Oh, they say, yeah, you're right on that, and they first antagonize me, but then when I go over it, they say, well, you're absolutely right, and we really don't understand the material as we should. And this is one of the topics that I discovered actually students still miss it. Why? Because they don't understand it well. So let's address that. And when I address this, actually, I like to refer you back to the biochemical aspects. See, I teach actually. I'm involved in teaching both, and I like to link those together. You see, let's first see, what are we talking about here? We're talking about a drug receptor interactions. We're not talking about anything like that. We're not talking about anything complicated. Exactly in a similar manner when we talk about enzyme substrate interaction. But we're not talking about simple enzyme. We're talking about complex globular proteins that are made up of more than one polypeptide chain. It's very much the same with the receptor. Receptors are made up of more than one polypeptide chain, and that's why you see this S shape here. When you look at the shape of the curve, it resembles an S, Greek letter. Why is that? Because you're dealing with cooperativity. You see here, that's the term that he used actually in terms of saturation of hemoglobin with oxygen, right? Each one has its own heme pocket that is able to bind independently with oxygen, but binds in a cooperative sense, which means enhancing the binding of the first molecule to the first heme pocket, enhances binding of the second, causes conformational change, and that's until you achieve saturation level. So if you put that in your mind as a professional student and as someone exposed to this material in more than one aspect, you will not forget it. We're talking about maximum effect that can be achieved upon saturation of the receptor with the drug. In the past, we used to talk about Vmax, maximum velocity that can be achieved upon saturation of the complex enzyme with the substrate. It's a similar manner. So what you're measuring here is the extent of the efficacy of this drug. See that? Okay. Efficacy of this drug. Okay, so this is the maximum that's achieved upon saturation. And if you really look at it in a logical sense, this resemble, we used to, in saturation of hemoglobin with oxygen, we used to state here partial pressure, which is proportional to the concentration. Partial pressure of oxygen, which is proportional to the concentration of oxygen, versus extent of saturation. You remember that? It's very much the same. But here we like to use the term effect, expressed as concentration per millimolar. So it's very much the same. We used to say maximum saturation. Now we say maximum effect. With enzyme substrate interaction, we used to see Vmax, and this is V0 initial, and this is substrate concentration. It's very much the same. We're not talking about different language here. So that's the efficacy is achieved by actually saturating the receptor with the drug. How much drug is needed to achieve a maximum efficacy? That's an important term to understand. In another term here, potency. What is potency means to us, and how can you evaluate it? So when you achieve this maximum efficacy, so you go 1/2 of it, and then you extrapolate the substrate concentration at half of this maximum efficacy, and that gives you ED50. ED50 here. So in essence, what we see here is the fact that the potency is essentially a measure of the amount of drug necessary to produce an effect of a given magnitude. Okay, so this is the important aspect to achieve. Okay, so which means actually for a number of reasons. The concentration producing an effect that is 50% of the maximum is used to determine the potency. That's what we're looking for. And this is designated as ED50. So in this figure, for instance, you have ED50 for this drug. So, and then you can with this manner, you can compare actually ED50 for more than one drug, right? So by looking at this curve, that's what you want to achieve essentially. And based on that, what is your parameter? Why you have to go through all of this hassle? Because you want to determine the therapeutic preparation of drugs that will reflect the potency. So this is a very important aspect to understand and to appreciate. Okay? So for instance, when you are dealing with angiotensin receptor blockers that are used by themselves or in combination to treat hypertension. Okay, so this is one decent parameter that you have to look at. Okay, ED50. What does ED50 means to you? What is this contributing factor? Okay, ED50 actually measures the affinity of the drug for the receptor. If you really recall the enzyme substrate interactions, right? And if you recall the hemoglobin saturation with oxygen, we had this 50% saturation, and we gave it term. We do that with enzyme substrate interaction, and we give it the apparent Km value, right? Which measure actually the affinity of the enzyme towards the substrate. So in a similar manner, we are dealing with here. You're measuring the affinity of the drug towards this receptor. Right? How much drug is needed to achieve ED50? That's the important aspect to understand it and to appreciate it. So I think we covered a great deal on what is meant by efficacy versus potency and what those terms mean. And when you have ED or EC 50, you're essentially measuring the concentration of the drug that produces a response equal to 50% of the maximal response. And that's what you like to get. So when you have two drugs, for instance, and presented to you in a graph, you must achieve and you must determine which one have a better affinity for the receptor and which one is the ideal one that you can address it to a patient. That's what you're looking for as a physician. Good, 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 good. Here comes the aspects. Here's what I like you to enjoy. Here, what I like you actually to sleep on this material. So you can understand what we're talking about. We're not talking about mysterious information. We're talking about lovely information that you, if you deal with it gently, it's going to work for you. So let's look at it. Okay, so you have a figure here that represents nicely the function of agonist alone. Okay, you achieved maximum efficacy. That's fine. We understand that. There is no problem with that. And then you added a competitive antagonist. So which way the plot will move? Is it to the right or to the left? And why? And how you rationalize that? So it's simple and easy here. Your parameter here is to look at the ED50, right? The effect of the antagonist on the ED50. So you extrapolate the concentration of the drug, of the agonist by itself first, okay, versus you extrapolate the concentration of the drug at half maximum efficacy, and you compare that with each other. So what does the antagonist do really for this plot? That's what you're interested in to understand. Okay, So you can see actually that both drugs here, the agonist and the antagonist, okay, they show the same efficacy. Why is that? Why is that, everyone? Why it shows the same efficacy? Because you are dealing with a competitive antagonist. The nature of the competition here is reversible. You see, in other words, if you add more of the agonist, so you can reverse this process. That's what we're talking about. So just exactly as the effect of a negative modulator for an allosteric enzyme. It's very much the same. We're talking about the same language. Okay. So you achieve this level, and that's why you, so what's that tells you about the ED50 here? What's that tells you? That tells you, yeah, they have the same efficacy, but the affinity decreases. You see that? The affinity of the receptor toward the agonist decreases. Why is that? Because you are dealing with the existence of a competitive antagonist, right? You can wash this off. How are you going to wash it off? By adding more of the agonist, right? So what you're looking for is kind of a temporary situation, a fine adjustment for the affinity of the receptor to the agonist. And that is the function of a competitive antagonist. Okay, so if you are asked in a national board exam, well, you have figure like that. How would you describe the function of this? And you have a label here, for instance, A versus B. So you have to say this is a solid competitive antagonist. Why is that? Because you have the same maximum efficacy, but they differ in ED50. Okay, good, good. We achieved our objective. Let's move on and see the function of an irreversible. See here, I love to take my time in saying irreversible here. You see, and even students sometimes laugh. I used to give a class actually to 250 students, and in the microphone I say irreversible. So they slow me down and they laugh. Why I want to say that? Because I want this to get to their brain. I want this to be solid in their hard drive. So when we talk about irreversible antagonist, what's the term implies here? It binds in an irreversible fashion. Okay. So let's look at it. So you're talking about, okay, the natural agonist alone just resembles the same curve in A here, but you added an irreversible antagonist. So you expect to see a decrease in maximum efficacy. Why is that? Because the nature of binding here is not reversible. You cannot wash this off. It caused an irreversible damage. So you're not going to get the same effect. You see that? So this is a point that you really like to appreciate and understand in terms of the partial of the agonist that binds in an irreversible fashion versus an antagonist that binds with a reversible fashion. Okay. So that's good, good, good. So we understand that. So let me get to a more complicated case. So you can see what I'm talking about here. You see here this beautiful plot here. So I'm confusing your guys here. Did you really understand what I talked about? Did you really have an appreciation about what I talked about in the past? If you do, so demonstrate it to me here. There is no other way around. So this is what we said. A drug alone can function in this fashion here. Gives you the sigmoidal plot. You have E efficacy, maximum efficacy that can be achieved upon saturation of the receptor with the drug. Go to 1/2, extrapolate the substrate concentration at 1/2. You got it. You got the drug concentration. ED50 for the drug alone. Okay, so that's clear-cut business here. Okay, if you have a non-competitive antagonist, so what you expect to see, actually, we already stated, you expect to see a similar effect with, in terms of maximum efficacy, but different ED50. And we fully agree on that with a reversible antagonist. Okay, okay, with a non-competitive antagonist that does not compete with the receptor. Okay, so what you expect to see is a decrease in maximum efficacy here. And as the term implies, a non-competitive can bind at any other site on the receptor, other than the binding site itself, other than the hot spot, just like the active site of the enzyme. That's the hot spot, right, where the substrate binds. So that's an analogous to this term. So how is going to show this effect? Well, you have to understand those macromolecules. The receptors are globular proteins, right? And they're subject to a fine conformational change. So you disturb this three-dimensional structure of the receptor, and as a result of that, you can decrease the efficacy. You can decrease the maximum efficacy of the drug. But what you're going to see actually is that the ED stays constant. Why is that? Because you're not competing with the drug for the combining site. See that? And this is proven to be the case with those non-competitive antagonists. I mean, we're not trying to create something from nothing. We show actually that this exists actually with certain drugs. Okay, we already talked about partial agonist. A partial agonist, so you can see actually the effect here. So when you look at C here and you try to compare it with the drug alone, so in essence, what you see here is not a full agonist effect. You see. So you're cutting this actually to half or 75%. Drug with a partial agonist, okay? So what you're going to see is you can achieve actually the same efficacy, but the ED, it changes. So this is what you have to see it here, according to okay, drug with a competitive antagonist, we already addressed that in the previous slides, not much different. You achieve the same efficacy, but the affinity of the drug actually decreases. So you're increasing the ED50 in the presence of a competitive antagonist. So it's a great plot where you see variation of effects here. And that's what you should be looking for actually when we talk about competitive antagonist, partial agonist, partial antagonist, and irreversible non-competitive antagonist and their effect. And that's what you need to appreciate and understand. Let's shift the gears and address therapeutic index. What do we know about this term? What is the significance about this? What is the significance about this in terms of drug-drug interaction? How we apply it? How we can go back to our first lecture and look at the table that I shared it with you, and I said, well, I'd like you to use this as a reference every time we cover a new class of drugs. Why is that? Because we already mentioned the essence of it, and that's what I like to share it with you. So, with an example, you talk about two therapeutic effects, a narrow therapeutic window here, and as the name implies, you really have to be very careful. You have to be very careful. So actually, when a patient goes to a primary care physician, okay, and he's not so sure, right? So I say, oh, no, I better send you to a specialist. Why is that? He doesn't want to get through a liability, right? He doesn't want to, because you're dealing here with a very sensitive dose here. If you exceed the limit, you may cause more harm than good to the patient, right? So you have to play it safe versus other drugs that have a broad therapeutic index, right? There is no problem with that. I can see that actually with respect to for instance, in some antihypertensive agent like lisonbril, for instance. It have, to an extent, kind of a little bit broader therapeutic window. Okay. But with warfarin, yeah, you have to be very careful with that. You see, this guy, it can cause more harm than good. So warfarin has a narrow or a small therapeutic index. Beyond that, so you expect to see the unwanted adverse effects to take place. And we said, well, the free drug is the one actually causes a problem, right? And you can see actually sulfonamides. Sulfonamides have a broad spectrum, a broad therapeutic index. So it's safe actually to state the concentration, right, within, of course, a window, but the window is much larger than warfarin here. And then the unwanted adverse effects takes place actually at very, very high dose levels. So this is what we like to achieve here. And that's a very important parameter that you need to address really when you talk about side effects of drugs and things like that. So from that, we can determine actually the therapeutic index, and that's a term that you have to be familiar with and you have to appreciate it. So what is it essentially? Therapeutic index of a drug is essentially the ratio of the dose that produces toxicity to the dose that produces a clinically desired or effective response in a population of individuals. It's essentially TD50 over ED50. That's the therapeutic index that you need to appreciate it and you need to state on your hard drive. There is no other way. Okay, so when we talk about pharmacotherapeutics, so our target here is to determine the therapeutic index here. Is it safe to use this drug or not? Okay, we're talking about the effect of drug concentration. We're talking about the patient's condition, history, right? What did you have before? Okay, did you have warfarin? Okay, can this be kicked out? Okay, what kind of medication do you have? Am I causing more harm than good to a patient when you prescribe a drug that can displace the other drug and show the severe side effects? Close monitoring. You have to tell the patient, well, I want you to call me in 2 weeks if this drug is really working good for you or what. You don't want to take a chance, right? In numerous occasions, the patient will call the physician again and say, oh, no, I was much better off than before I took the drug. So, oh, okay, come over here and stuff like that. And then the physician prescribes another drug. Essentially, the physician deals with these aspects. Okay, tolerance and dependence is interactions. Drug-drug interactions play a major role. Yeah, we already talked about cytochrome P450, this beautiful system that have 5 different isozymes, have a specific specificity toward individual substrates, have inducers, have inhibitors. You want to play it safe. You don't want to cause any harm to this patient. This patient is aged, so what do you consider? Well, his P450 is not as strong as a young man 20 or 25 years old, right? I mean, he has more wisdom for sure. He's a very wise man, okay, and seniority provides this wisdom, but of course, unfortunately, his P450 will not function as effective one. So you have to be careful with that, right? You don't want to lose this guy. Right, you better often leave him alone. Yeah, I was just visiting actually Savannah, and I saw some of the historical places, and they said actually during that time, in about 100 years ago, okay, they said the risk actually of going to a physician was much worse than if the patient stays alone by himself due to the infection and to the problems that took place. So you have to deal with a delicate situation like that. Drug-drug interactions has to be one major factor. You really need to look at side effects and adverse drug effects. Are those minor side effects or are there serious side effects? How is the history of the patient in terms of handling drugs and things like that? This slide here shows nicely the therapeutic index. As I said here, you're dealing with TD50 or and ED50 here. So toxicity, TX, toxicity at D50 and ED50. This ratio is a determining factor. And to be more precise, so you can use the standard margin of safety. What's that tells you? So the toxicity D1 minus 1 times 100 over ED 99% of the population. So that determines the percent to which the dose effective in 99% of the population must be raised to cause toxicity and only 1%. So this is very safe to be utilized. So those terms can be used effectively on that. What is a beautiful figure here? Shows us colorful, nice. You cannot ask for more than that. That's a beautiful one. So this is what we're talking about here, right? You see here the ED50, and you see the toxicity range, toxic effect here. And it shows actually those ranges very nicely in this pattern. So those are the terms that you really need to appreciate and to have it straight on your hard drive. And probably an example like warfarin, which is an example with a small therapeutic index, can be placed on your hard drive as well. As the dose of warfarin is increased, the greater fraction of the patients respond for this drug. And actually, the desired response is about twofold increase in the prothrombin time until essentially you achieve, you get the response. But at very high levels, so the toxic effects do exist. Okay. And namely, you can use this with a high degree of anticoagulation, and that may result actually to severe hemorrhage, as we said. So it does have a therapeutic index which is low, and that has to be taken in consideration with that. And for some patients, actually, you expect to see the hemorrhage take place with individual patients. With penicillin, as I said, it's very safe and common to give doses in excess, often about 10-fold of excess, which is minimal, required to achieve the desired case. Okay. And in this case, actually, as if you're really aware of the pharmacokinetic terms that we addressed, so the bioavailability does not critically alter the therapeutic effects. I think I wrapped for you all what you need to know about pharmacodynamics and how you differentiate it from pharmacokinetics terms. Look at the figures, look at the examples, look at cytochrome P450, live with it, enjoy it. I wish I'm sitting in this class and enjoying this material, but your people actually got it neat. We did not have those resources, actually, and I used to hit myself, actually, and sit on a solid textbook that is made up of 2,500 pages, and I have no other choice, just other than sitting and analyzing each page and making a summary for it by the hard way. But you have it all. You have it recorded. You have the decent slide presentations here. You have experts, actually, like Dr. Minarsik, or like myself, or Dr. Jim, actually, trying to pass on this information to you. So I guess you guys, you are on a golden stage of your life, okay? And I sometimes I wonder, really, when I look at it, and I thought those can be helpful to the students, but sometimes I feel very disappointed that the the scores are not really high enough to make a valid judgment that the increase in technology did assist the students a great deal. In the old days, I have actually friends who came from Great Britain without looking at the practice exams or without joining Kaplan or Doctors in Training or my courses or any of the others. And they sat in the board exams and they passed it from the first attempt. And that's what I call real education. So I hope I pass on this information to you nicely and easily. The next topic, and I see actually that the time is not in our favor now. I selected this topic because it acts as a transition, actually. So you covered the basic principles that you like to address here, but how about now we hitting PNS, we're hitting CNS, we're hitting cardiovascular, we're hitting specificity of receptors, we're looking at subtypes of receptors, we're looking about distribution of those receptors in different tissues, and we're looking at the effect of drugs on these subtypes of receptors. Which one acts as beta blockers, which one acts as an alpha blocker, why, what is the outcome of this, what is cholinergic receptors, adrenergic receptors, what is nicotinic receptors, muscarinic receptors, subclasses, M1, M2, M3, M4, M5, and all of this fine material. And in order to understand it, you have to have an appreciation about signaling mechanisms, right? We like to see what this whole topic is all about, what muscarinic receptors look like, how can they be initiated, and then before we move on and talk about cholinergic antagonists, cholinergic agonists, specific receptors, specificity, so we can have an appreciation on that. We have an appreciation about if you give a drug which have a high affinity for a muscarinic receptor, but still combined with a nicotinic receptor. So if you exceed the limit, so what kind of problems will you get, vice versa? Do you have to give a drug that is specific for M1 or M2? Okay, so you play around with that. Is it hard? No, it's not hard. Is it understandable? Yes, it's understandable. Does it require you a critical thinking? Yes. Do you have it? You may have it or you may not have it. Okay, and that's the target. It's not an anti-infective drugs, right? We're not talking about antibiotics that you can set and memorize it, and you have it in microbiology, you have it addressed in numerous other classes, and those people who have the ability to memorize this stuff, it's a piece of cake. And there are some questions on that. But for those people who cannot rationalize this, they have a little bit difficult time when they deal with cardiovascular, when they deal with PNS. And they feel, oh, that's extremely tough, extremely hard. Why? Because they do not want to look at it at the molecular level. Why? Because they do not want to play the chess game approach that I directed you to it. So if you do like to understand this material, I urge you to send a message to Dr. Minarsik and tell him I do love to join the chess game club. And I will be more than happy to help you with that. With that, I think I'd like to wrap today's lecture on this final conclusion, and I'd like to sleep on the material a little bit and give me a call or send me a message or visit my website. That also Dr. Minarsik, you're going to see him on the website too, and we're going to have an outstanding activities starting from mid-June. So thank you all for listening to me and for sharing with me some of my enjoyment, and that is how to look at the big picture, how to play the chess game approach. Appreciate it, and have a great afternoon. Bye-bye now.
Thank you, Dr. Zaiden. Thank you very much. You know, one of the students has their hands raised. If you would take a question, you could either unmute that student, or I could do it for you. Do you
why don't you do it for me?
Okay, I'll unmute a student whose name is Key, Q-I-C-A-I, and that student wants to ask you a question.
Sure.
And here she is, or he is.
Yeah, hi, Key. Hello?
Okay, well, if we can't hear them, that means that maybe it was a mistake or maybe they don't have a microphone. There is another question from Antoinette Brown, however. I'll put
Antoinette?
her.
Okay.
Antoinette Brown. Here she is. Hi, Antoinette. How are you doing?
Where are you now, Antoinette? I can't hear her.
I can't hear her either. Maybe that was a mistake as well. But I usually check the attendee list to see if any.
Let me do that. Yeah, I just minimize this. Okay, let me. Yeah, okay, I have it here. I have actually 19 students here.
That's right, and 2 of them had their hands raised, but when I unmuted them, they couldn't speak. So maybe it was a mistake, or maybe they didn't have their microphones plugged in. Also, the thing that you could do is click on the question box to see if there are any questions asked.
Yeah, chat. Question box. Yeah.
And there's nobody that's at the question box.
Yeah, I do not see any of the questions. Yeah, so that's.
I also opened the chat box. So these are all little things you could do. I'm going to see if Antoinette.
Yeah, I like to ask actually a question. Well, do you have a clear understanding of the material that I covered so far?
Okay, well, here's what you do, Henry. Just ask everybody if they would like to answer your questions, just to
can respond to it. Yeah.
Type them into the question box, and that you can see what they're saying. For example, student right now, Aruna Rithi, she just said, "Thanks for this wonderful lecture."
Oh,
so any question
I see it.
All of the students, they can answer. For example, I usually ask them, "Can you hear me and see me well?" And then they all respond yes or no.
That's good. That's good. Yeah, I think I got it here. And I'm glad that you really learned something out of the lecture. And my objective here, or Dr. Minarsik, or the effective educator, is actually we like to guide you to the critical thinking. That as a professional and at this level, it hurts me a lot when I see a professional student trying to get the shortcut. He just want to memorize some stuff, and I cannot trust a physician to examine me. He wants to use this shortcut. I took so many courses actually, and I wasn't concerned if that's going to be on my transcript or not. I like to learn. I like to see the big picture, and that's the case actually with all dedicated, effective educators that put in their mind their mission. So with that said, please, please, please try to take the advantage of this. Try to take the advantage of having someone like Dr. Minarsik or me who is willing actually to pass on this.
And Dr. Zaidan, you might be able to see some of the comments now in the question box. There have been several other comments.
Oh, okay. Let me read it. Yeah, okay. Thanks to a wonderful full lesson. That's great. Awesome to have this online lectures. That's good. Okay. Appreciate it. And please also visit my website, and Dr. Minarsik is there, www.theeducationcenter.com. Okay. And it's going to be revised actually in the next 2 weeks, and we're going to have a great activities. And I see here.
Remember, every time you ask the whole class a question, they can respond by typing their answers into the question box. For example, we just saw a 4th question that came up.
How long is the course going to take, meaning in months? And to answer your question, I'm actually involved in several activities now. And one of it is actually my website and my activities, and how we can assist the students at how we can reach the target and compete with the commercial ones and with much less cost-wise and much more productive avenues. Dr. Minarsik shared with me my concept along with other educators, and that's what we are working on it now. So I cannot really give a promise of how long that does it take. I like to leave this up in the air, and especially actually I will be involved in some travels and things like that. So I'd like to leave it open. I probably by the time when I settle down and I set my goals, I can share with you some of this concept. But please, you have my email, you have my telephone number, and you have my website. So please feel free to contact me at any time, and I'm here to help you out to achieve your goal. Dr. Minarsik also shared with me the same concept, and I have my former students actually have a very high regards for my mission and my belief. And I appreciate having all of you in the class. Thank you all. Appreciate it.
Do you know how to end the webinar, or would you like me to start?
Yeah, I think I did that before.
If you click under File, it'll say on the bottom, Exit Webinar, and then everything will shut down.
I do that, exit, end of webinar. So thank you all, and bye-bye now.
Thank you very much, Henry.
Bye-bye.
The organizer has ended.